Okay, Lindsey will be here shortly. She had an e-board meeting, so we'll go ahead and get started. Kishore covered the week 1 stuff with y'all last week. I watched a bit of it. He did a really good job. So my goal here is just to quickly go through that stuff. We're going to go through and just, I'm going to point out some things that, so just to reiterate some of the points that Kishore went over, some of the points I feel were important. These are my slides from last term. So they're similar to the ones Kishore used last week. But then we'll take a break and then we'll get into the stuff that's new from this week. Next week, y'all are going to get into more of the histology and physiology of the muscle and bone and stuff. Unfortunately, we won't have a review next weekend because our first term, Lindsey and my first term 4 exam is that next Monday. So yeah, when is y'all's exam actually?
March 29th.
What day of the week is that? Is that next week?
I think it's Monday.
Oh, it's the following.
Yeah.
Okay,
so
maybe
next week, but the week after.
Okay, so maybe we can have a review for y'all the weekend before. We'll say tentatively. Yeah, that'll be good. Okay. Yeah. So let's take a look. So again, Scrubs DES, you could find the slides that we're going to do there. I will post a PowerPoint or a PDF with the answers to these questions. Well, I mean, I'm sorry, with the explanations to these questions after as well. So y'all could just see the explanations, but we're going to go through them. You could see additional resources, stuff I found helpful when I was doing MSK. On the Scrubs page, just look for the additional resources, and Lindsey posts stuff as well. As we keep saying, do the Grace questions, make sure you get through them. The test is going to be clinically relevant. So you need to understand not just the insertion and origin and insertion and the different muscle groupings and stuff, which are medium to low yield compared to the clinical applications. So the book, what the type of questions the book is going to ask is going to be the type of questions you'll see on the test. So I would very much lean toward maybe going through post reading and looking at the lectures once or twice, and then trying to do these Grace questions. You know, try to get through them, at least the ones that are assigned twice, to make sure the topics that are the topics that have questions that are the more questions a topic has in Grace, you can consider that more high yield, right? So some muscles have like 15 questions asked about them. Consider that very high yield, right? The more questions. And as I mentioned earlier, you can download the Inkling app and put the book code in there, and it's an interactive way to do the multiple choice questions. But make sure you get to these. If you can answer these questions, you should do well on the exam. Now, you don't need to worry about this right now, but it is important. You're going to do this cadaver lab or this end-of-module lab exam at the end. So you're going to have like cadaver lab images so that you'll have to identify those. They'll be first or second order. We'll talk again about it when the time comes. But as for cadaver images on the exam, there won't be any. There may be a few Netter's questions or Netter's images about questions. But just keep in mind that this is going to come back up again when you do your end of module lab exam. All right, so we'll look at the back and spinal cord. We could go ahead and quickly do this. Y'all could just private message me your answers real quick. The lab exam is going to be cumulative, and it's going to be at the end of the term. So a good bit of it is going to be MSK, right? But there'll be some cardio images, respiratory, renal stuff. Okay, so where are we talking about here? Now, terminates at the disc between which of the following levels? So L1 and L2, remember that's the conus equina, I'm sorry, the conus medullaris, right? That's the end of the spinal cord. Now, the important point is, below that, you still have nerves, but it's called the cauda equina, which means horse's tail. But so they're like independent fibers that run down. So you have the cerebral spinal fluid in there. And the point is, when you do a spinal tap or a lumbar puncture and you want to get CSF out, you want to go into the area of the cauda equina. It's kind of like if you imagine, you know, like like putting a syringe through hair, right? The hair is just going to separate. If you go above that, you're going to hit the actual spinal cord, right? So the cauda equina is about L1, L2. So you want to go, definitely want to go below that. That's a good point to know. And you can see that here. See, this is this little area here is the conus medullaris, and this is the cauda equina. So if you do a lumbar puncture down here, L3, L4, L4, L5 area, the cauda equina is just going to kind of separate, and you can get the CSF and not harm the patient. All right, let's try this one. Right, so Reynolds disease is this overstimulation of the sympathetic system. If you have it, you know you have it. In the cold weather, your fingers turn purple, the tips of your fingers and stuff. So it's like an overactivation of the sympathetic nervous system. So that's what we're testing here. Where does the sympathetic nervous system come from? The lower cervical and upper thoracic sympathetic fibers. Okay, so they thoracolumbar is the area of the sympathetic system, where the parasympathetic is craniosacral. So you think of parasympathetic as the outer aspects of it, and the sympathetic system is more of the inner aspects, yeah. So thoracolumbar is where those sympathetic fibers are going to come from. All right, try this one. Okay, let's take a look at this. So the question is, dorsal primary rami, what are we talking about here? What is innervated by this area? So it's gonna innervate the intrinsic muscles of the back, okay? Whereas the ventral primary rami is gonna innervate all the muscles of the anterior side and the more external muscles of the back. So that's why, so for dorsal primary rami, we're looking for the intrinsic muscles of the back, and that's the semispinalis capitis, right? That's more of an intrinsic muscle. Now, here's the thing you could do. So let's just say you don't know, right? And you're trying to differentiate. Sometimes you could try to group these muscles together and see which one stands out. So if you put these together, A, B, C, and E are all external muscles. So if you think of it like that, semispinalis capitis is one of the ones that stands out. And sometimes if you don't know and you're trying to, you could try to use the test to your advantage and learn it that way. So the dorsal primary rami is for those intrinsic muscles of the back. Semispinalis capitis is one of those. All right, so yeah, and you could see that here, intrinsic muscles. And then I put this here just so y'all can look at those. Again, so when you're looking at this, obviously the innervation is important. The blood supply is important as well, especially if there's an anastomosis, right? Because they could tell you if there's some sort of blood clot or some sort of injury, how do you get alternate blood supply to that area? Now, they're also, yeah, ventral primary ramus is going to be the extrinsic muscles. Yes, the more external or extrinsic muscles, yeah. And then the functions are going to be super important, because if you have some sort of lesion to the innervation of that area, it's going to affect that function. So what does the muscle normally do? And if there's a deficit, what is going to happen in response to it? So keep those separate, right? There's a difference between what it can do and what's going to happen if there's some sort of injury, right? So they can ask you either way on the test. And I'll try to point that out as we go. All right, let's take a look at this one. All right, so pretty straightforward. You kind of either know it or you don't. Does anybody know what this is called?
Sacrococcygeal teratoma.
Yeah, sacrococcygeal teratoma, right? So a couple of important things. Primitive streak, buzzword, you either know it or you don't. Also, this contains all three layers, all three germ cell layers, right? It's in your notes. I think I have it here. Yeah, so you get derivatives from all three germ cell layers. So you could find those, and primitive streak is going to be one of those buzzwords you're looking for. So this happens early on in development. Common tumors seen there. Remember that all three germ layers may be found. Primitive streak, sacrococcygeal teratoma. Very good. All right, let's look at this one. These are fairly common, so it's often tested. Yeah, y'all got this. Just to point out, when Lindsey gets here, it's going to be easier for her to man the chat while I do this. But I'll try to answer the questions as we go. In regards to embryology, this is going to be as you go through the terms. For embryology, the clinical stuff, again, by far the most important stuff. So focus on the clinical aspects. The school knows, everybody knows it's embryology could go as deep as you want it to go. So they really do focus on the clinical aspects of it. Okay, so protrusion of the cord and the meninges, right? So myelo is the meninges, and sorry, myelo is the cord, meninges is the meninges, and it's sealed off, right? That's how I remember it. So if it was just the meninges and not the cord, it would be a meningoceal, but because you include the cord, it's a myelomeningoceal. So kind of one of those, the longer the words, the worse it is, right? You definitely don't want this protrusion. So this falls under spina bifida. Does anybody know what the mom is supposed to take prenatal? Folate, right? Folate is the
9.
Yeah, exactly, right. So folate's a huge, important factor, important vitamin as a prenatal vitamin to prevent these neural tube defects. Remember, when they talk about spina bifida occulta, a lot of times the only way they diagnose this is there's that little tuft of hair. So they're asymptomatic, but they have a tuft of hair. But again, when you start adding stuff to this bulge, it gets a lot worse. Yeah, maternal folate. All right, and we kind of talked about these. Myeloschisis is just open, right? It's not sealed off, right? It's sealed off. So the myeloschisis is open. Obviously, that would be the worst, right? This is just an important slide. It's one of those things, the neural crest cells are just always going to come up. So it's better to just learn these now. These are the things, some of them are not exactly intuitive, but these are the neural crest derivatives. So when in doubt, it's neural crest cells. So for right now, there's more than this, but for right now, if y'all know these, you should be good to go. Neural tube derivatives as well. But you could see that the CNS and PNS comes from here, this neural tube, and then the neural crest derivatives, again, are kind of all over the place, but most of them deal with, at least for right now, deal with the nervous system. All right, let's look at this. Right, good. So key buzzword here is anterior dislocation. Spondylolysis is just a fracture. When you look at that Scotty dog, if you see on the oblique view of the Scotty dog, it's a fracture of the pars interarticularis, and that is the collar of the Scotty dog. Now, if you get an anterior dislocation of that superior vertebrae, or that superior portion of the fracture, then you get spondylolisthesis, okay? So again, the bigger word, the worse it is. Spondylolysis, just a fracture of the neck. Again, it's called the pars interarticularis. It's the weak point, okay? On the vertebrae, when they come together, the pars interarticularis is kind of a weak point, right? That neck of the Scotty dog, so that's what fractures. Okay, so if you get a slipping of the anterior portion of the fracture, spondylolisthesis. Okay, scoliosis, right? It's lateral, right? It looks like an S if you're looking at the patient's back. Whereas lordosis, the way I remember lordosis is like a pregnant woman, right? How she has to kind of lean back. That's lordosis. And you could see here, this is an oblique view. You could see the Scotty dog. You could see this is a fracture of the collar. This is called the pars interarticularis, right? That weak point. And you could see here we have this slipping of the superior portion or the superior disc here, superior vertebrae. And this anterior slipping is going to be spondylolisthesis. Good, and you could see it here, right? Spondylolysis. Kind of hard to see the Scotty dog, right? You could kind of see him outlined here. It's the same direction as this one. But again, you see the little neck fracture. So just for testing purposes, if it's just a fracture, okay, so technically to have spondylolisthesis, you have to have spondylolysis. Okay, I went down a rabbit hole with this. There are exceptions, but you just need to know if there is anterior slipping, it's going to be considered spondylolisthesis. All right, it's just it's intuitive that it would include the fracture. Okay, so if it's just the fracture, spondylolysis. If you have anterior slipping, regardless if you have the fracture or not, which typically you will, especially in the lumbar area, if you have anterior slipping, spondylolisthesis. They could put images on there, yeah, for sure. Like this would be a good image for you to notice that these don't line up. Again, the way you would check is you kind of draw a line and make sure they all go together. Then all of a sudden you have this huge gap here. But any sort of dislocation like this, you're going to consider spondylolisthesis. I assume maybe they had both the answers right on the IMCQ. I'm just saying for testing purposes, if there's an anterior slipping, I would go with this for sure.
Hey, Brady, I just put a question in the chat. I don't remember the exact question. I was asking if anybody else did. They gave us a question that had 3 options. One was spondylolysis, one was spondylolisthesis, and then they gave us a third one that was like spondylolytic spondylolisthesis or something. And
yeah.
I could not come up with what the third one was that was different from the first one.
Both of them.
It was both of them, spondylolytic.
Yeah.
I'm not sure. I don't remember coming across that. Yeah.
Is it the one from there was an image and it was because you could see that it slipped and there was also a fracture. That's why I'm saying I think it was in the IMCQ. It was just basically showing both. And so that's why, because there's some x-rays that will only show either the slip or the fracture, but that specific one showed both. And so that's why it was both.
But we just sort of defined spondylolisthesis as being both. So why would you need a third word to describe both?
Yeah, I would hope on the exam they wouldn't get into that much detail, because I don't remember unless they added that to y'all's slides, I don't remember coming across that.
No, they never defined it. They just threw it at us in the MCQ.
It wasn't a new word. It was just spondylolisthesis and spondylolysis combined, plus and plus. There was a plus in between. And
okay, so yeah, if they put that together, then obviously it's fracture plus a slip. So I think it's more detailed than you need to get into. Sometimes in the cervical area, you can have slipping of the disc without a fracture. But what y'all are talking about right now is the lumbar area. And typically that's a high impact area. So when you see that fracture, you're gonna have, or when you see that slipping, it typically involves a fracture. So just keep it in mind. If they put both on there and there is a slipping, then yeah, I would go with that. So let's just say for completeness sake, look for the fracture, look for the slipping. If they're both on there and they're both an option, put them. But typically it's understood that if you have some sort of slipping, the fracture's included. Okay, but again,
Nagam Nagam, is that her name? I'm not sure. Just found it, and it wasn't an and, it was spondylolytic spondylolisthesis, which just seems really redundant to me.
Yeah, I guess they were just trying to be complete because maybe students were emailing them. So I think spondylolytic spondylolisthesis or lithiasis is going to be including both of them. So if they put that on the test, that would be considered both.
Okay.
Yeah.
It
Yeah,
was
just
just,
for-
it seemed dumb to me because they literally defined spondylolisthesis as being both of them. So
Right.
it was
I
just
mean,
kind of mean. Anyway, thank you.
No worries. I think it's just, there's just those, like I was saying, in the cervical area, you can get slipping. And so like, I guess clinically you would put spondylolytic, spondylolithiasis. But you know, just be aware of that. Like if there is slipping, don't just put spondylolysis, right? If there's slipping of the disc, you want to include it all. I imagine they will be straightforward on your exam though. They don't want any sort of confusion. All right, let's try this one. So we're talking about the dens here, right? That's the little part that of the axis that slides over the atlas, C1. So it's often injured in high impact collisions. So what holds that together? It's the transverse ligament of the atlas. It kind of sits behind the dens and kind of holds it taut against it. So if we look here, this is going to be classically type 2 is the worst. And the reason is because if that transverse ligament goes across it right there, sometimes because of the proximity of the ligament to the fracture, it can cause compression of the vasculature. Okay, so if you get that, then you can get avascular necrosis to the this part of the dens. So typically, just remember type 2 is the worst. This would be a great image to put on there for you to recognize. You know, it's pretty straightforward. You should be able to see. Maybe not to differentiate them, but you could definitely tell this is a fracture of the dens. Again, high impact collisions. All right, try this one. All right. So basically what we're asking for, if you have some sort of herniation between L4, L5, this is a super important because so many people have back problems in the United States and around the world, that this is a common thing, these disc herniations. So if you have an injury to L4, L5, what nerve is going to be affected? And that's going to be L5. It's going to be the one below. So it ends up going below, below, above, below, and we'll go into this here. So let's look at the cervical vertebrae first. If you have C4, C5, the C5 nerve is going to exit above. So if you think of it, C1's here, C2, C3. C3 is going to be above the vertebral C3. Let me see, actually, let me annotate this. Okay. So this would be C1, right? Above C1, C2, C3, C4, C5. So when you think of between C4 and C5, C5 is going to come out above. Now, what ends up happening is you actually have a C8 nerve, even though there's no C8 vertebrae. So what that ends up doing, this is C8 right here, it bumps all the nerves down one, right? When you get to the thoracic region. So here, when we see it now, since there's a C8 right here, everything gets bumped down. So T1 is below T1, right? So everything T2, T3, T4, T5, T6. Now T7 is going to come out here. Okay, so any sort of herniation will affect T7. So now you're going above. So when you think about it in the thoracic region, between T7 and T8, the nerve that's above is going to come out. Okay. Now, what's tricky about the lumbar region is that there's a nerve that exits, okay, but it exits above the disc. Okay, so L4 is going to exit here. Let me draw it. Is going to exit here, But when this disc herniates, it's going to miss it, okay? So L4 is spared. So the next nerve that comes out is L5. So that herniation is going to hit L5. So even though the L4 nerve exits between L4 and L5, it exits above the disc. And because of that, L5 is going to be what's affected. Okay, so I think I have one more slide to kind of, yeah. So if you just want a brute memorization, remember it's below, above, below, okay? And that's for the compressed nerve, the nerve that's affected, right? Below, meaning C2, 3C, C3 is affected, the one that's below, above T4 of the T4, T5. And even though L4 exits, the one that's below is affected. Excuse me, and you can see that here. So you have this disc that, so this is L4, this is disc L4 and disc L5, right? So L4 is coming out below the L4 disc, but you can see if this, I'm sorry, above, it's going out below the L4 vertebrae, but above the L4 disc. All right, so if this disc herniates, L4 would have already crossed out. So L5 is what's affected. All right, so it just takes a couple minutes to like make sure you get it down, but then once you get it, you should be good. All right, so let's look at some upper limb. Go ahead and try to answer this question. All right, let's take a look. So this is the acromioclavicular, from the acromion to the clavicle, right? You could see this clavicle separation up here. And that's typically what happens. And if you're wondering why it pops up like this, that's because it's attached to the sternocleidomastoid muscle. You get into that when you do head and neck with neuro, but that's why it pulls it up, because there's another muscle over here that attaches to the head, pulling it up. So the acromion, I think I have an image of it, right? So when we look at here, there's the acromioclavicular joint right here, and you can see that's what separates. And then this is the coracoclavicular. Typically that, this does have a separation here. You can see the coracoclavicular, but what they're worried about is the acromioclavicular. You can see how the separation here is supposed to be here, is not supposed to be there, right? So typically coracoclavicular and coracoacromial won't be affected as much, but the acromioclavicular is the one you typically need to worry about. Anything that's actually attaching to the clavicle, right? Because the clavicle is the bone that tends to separate. All right, let's look at the brachial plexus. So it does get a little confusing. You can go on YouTube and they could show, there's like videos how to draw it in like 30 seconds. It's cool if you could draw it, but again, it's, you know, you're focusing on the clinical aspects, right? So you can use this mnemonic to remember roots, trunks, division, cords, branches. Real Texans drink cold beer. That helps to break it down into the different sections. And we'll talk about it a little bit more, but let's do a question first. This is one of the clinical aspects of it. All right, so this is the classic presentation they're going to give you. Okay, they're going to say there was a difficult birth, and so the doctor had to pull the baby out usually with traction, okay? So what ends up happening, so if the baby's head is pushed to the side, sometimes you can tear the upper brachial plexus. So if you kind of tilt your head to the side, you could feel it kind of stretching, right? That's the upper brachial plexus. So this is called Herb Duchenne palsy. And you can see here, if you look at the child, they call this the waiter's tip position. Like if a waiter was walking away from the table and they put their hand back for like an extra tip. And this, so if you remember this, then you can remember the presentation. So if you injured that upper brachial plexus, the child's gonna end up medially rotated, and the arm is gonna be adducted, right, against the thorax, and then the hand is gonna be flexed. So what we see, let's do this one real quick. This is a same rationale here, and then I'll explain the rest of it. Okay, so this is one of those things you need to watch out for in the exam. They're not asking you what position should the baby be able to be in. They're asking after this injury, what can the baby not do, right? So you have to remember what is the action of the muscle or the nerve being affected, and then what is what is the deficit, right? So what can it do? What should it be able to do, and what can it not do now? Right? There's a difference. So they're asking you, what can the child not do? Okay, so remember we said this waiter's tip position. So arm is against, so it's adducted, right? ADD against the chest. It's medially rotated and the wrist is flexed. So if the arm is medially rotated, the child's gonna have difficulty laterally rotating the arm, right? So they could have easily asked you, what position is the child in, right? So it's medially rotated, the arm, but it's asking what would you not be able to do? And it's the inability to laterally rotate the arm. So just keep that in mind. You don't want to get tripped up on the exam with stuff like that. So these are the muscles that are affected. The suprascapular nerve, that's going to keep the arm adducted. The axillary nerve, again, as well, because that's going to prevent abduction. Suprascapular is also going to affect the medial rotation of the arm, and then musculocutaneous as well. So they use the SAM mnemonic. And if you think about it, all of these nerves are going to come off of that upper brachial plexus, right? That C5, C6 area. And we can look at that again here. But one of the things that really helps me to compartmentalize or to categorize different diseases, and it helps me remember them. So Herb Duchenne palsy and Klumpke's palsy are basically completely opposites. I think I have a question. Okay, first, again, this is upper brachial plexus, that C5, C6 area coming off. Again, we talked about suprascapular, axillary, and musculocutaneous. So suprascapular, 0 to 15, axillary, you can't go from 15 to 90. Those degrees that we're talking about now are important as well. And then the trapezius and the serratus anterior help you go from 90 to above the head. So if they talk about serratus anterior, a lot of times they talk about somebody having difficulty combing their hair, right? Because they can't lift their hand above their head. But again, we're talking about these axillary, you can't abduct the arm, like we said. Musculocutaneous, loss of forearm flexion, right? So, and the forearm will be supinated. So these are the muscles, these SAM muscles that are involved. Again, it's primarily C5, C6. The question they'll talk about is the kid that, the child difficult delivery. Now let's look at, okay. So wing scapula is involved with the serratus anterior, right? That's the muscle underneath by your ribs, by your thorax. This upper brachial plexus isn't a primary concern here. So if they talk about a wing scapula, they're talking about the serratus anterior injury. Okay, so again, this is just another picture of the child with the waiter's tip position. This is great. I love this. So let's just take a second to go through this. If you label your hands C5, C6, C7, C8, and T1, right? You could do 3 musketeers. That means the musculocutaneous comes off of C5, C6, C7. Axillary is assassinated like a gun, C5 and C6. 5 rats, rats is radial, all 5. 5 mice, mice is median. 2 unicorns, that means the ulnar comes off of C8 and T1. Because, you know, the brachial plexus kind of crosses over and stuff. So if they talk about some sort of injury, you can trace it back up to the brachial plexus using this. So I really do like that. Now, as I said, the Klumpke's palsy is the opposite, whereas Herb Duchenne's palsy is the upper brachial plexus. Klumpke's palsy is the lower brachial plexus. So the situation here, remember with Herb Duchenne, the child is kind of stretched, right? You're pulling the upper brachial plexus. With Klumpke's palsy, what they tell you is some guy was hanging from a tree, right? And he got pulled really hard. Like he fell from the tree and he tried to grab onto a branch. So here you're tearing the lower brachial plexus, right? So completely opposite. So again, that helps me compartmentalize things in my head. So we could talk about some of the problems here. And I want to try to incorporate this into it as well. So yeah. So again, let's look at this. So opposed to being able to draw this, again, it's nice. It's a cool, I don't know, drinking party trick with med school students only, because nobody else finds this interesting. But if you know the branches that come off of this, you should be good, and about the area that they come off. Again, long thoracic is going to be serratus anterior. It's typically spared in this in this Herb Duchenne's palsy, so you really wouldn't see an injury there. But knowing where these comes off is good to know, and you could kind of follow these down. Some of these are not as important, but by all means, the most important thing is going to be the branches. We use the mnemonic MARMU, musculocutaneous, axillary, radial, median, and ulnar, right? So you can see those here where they come off of, knowing the chords they come off of as well. But again, if you use the little 5 rats thing or the fingertip thing, you can figure these out really easily, what they come from, because it's not exactly intuitive just by drawing it, but you could see where everything comes from. I thought I had a question on Klumpke's palsy, but I guess not. So again, let me just point this out. The question they'll tell you is some guy was in a tree. He was holding onto the tree and it tore the lower brachial plexus. So lower brachial plexus, what are we talking about? Probably C8, T1. So then what's going to be affected? Well, we know our unicorn's affected, right? You're going to affect musculocutaneous. I'm sorry, you're going to affect median and you're going to affect radial, right? Those all involve C8 and T1. So the clinical aspect of it, they call it Klumpke's paw, right? The hand's going to be sort of like this. And that's because you can't fully extend, you can't fully flex. And again, this has to do with flexion as well. So they'll present, even though it's a brachial plexus injury, you see the clinical effects in the hand because these all involve the hand muscles, okay? So look out for that. Herb Duchenne's, difficult delivery, Klumpke's palsy, guy hanging in a tree. All right, let's see. Okay, let's move on to the upper limb. So again, a lot of buzzwords here. If you have a fracture up here at the neck of the humerus, typically it's the axillary nerve. If there's some sort of dislocation, right? Remember the posterior circumflex humeral artery wraps around the humerus, right? Like makes a ring. So if you dislocate the humerus, a lot of times you can injure the posterior circumflex humeral artery. So those kind of go together. If you have a mid-shaft fracture, they talk about this a lot. It's going to be the radial artery. That's because it runs, the radial nerve. And that's because it runs right along the shaft. It's very close to the bone. And the deep brachial artery runs with it too. So again, we're taking a lot of the basic anatomy points and we're putting a clinical aspect on it. That's how the board is set up. That's how your exam is going to be set up. All right, let's take a look at this one. All right, so this is a good teaching point here. So this guy gets in a motor vehicle accident, and you could see he's unable to extend the left wrist, the fingers, and the thumb, right? So when we talk about extension, particularly in the hand, we're talking about the radial nerve. Now, the question comes here, why is he able to extend the elbow? And I'll let you know, it's because the nerve that supplies the triceps, it exits prior to the mid shaft. Okay, so you always want to look, you want to get the most, you want to find the most proximal area that is injured that includes all of the symptoms, right? So that's going to be difficult, you know, on the exam. You want to find all the way until you locate the most proximal area on the arm to where everything is injured, and then you find something that's intact. So practically you can do it like this: unable to extend the left wrist, fingers, and thumb. So you know the radial nerve's affected down here, but he can extend the elbow. Well, at the point of the let's see, clear this. At the point of the radial nerve, at the mid-humerus, all of these symptoms are involved, right? So the most proximal injury that's listed here, that includes everything. Now you could say, well, couldn't it be affected a little bit lower down? Technically, maybe, but you're looking for the most proximal area. Okay, so that's the point I wanted to get there. So yeah, but the nerve that goes to the tricep, it leaves prior to the mid shaft. It leaves very high up. So that's why the injury is actually distal to that point. Okay. Yeah, and I just put this here. The branch to the tricep exits the radial nerve prior to the mid shaft. So even though it's a mid shaft injury, it's not going to affect the extension. It's not going to affect the triceps. So these are just little things they like to test on because they're just little caveats and stuff. So again, these are tested in grays, and you'll see those there. All right, supracondylar. And whenever you hear supracondylar, you're thinking of a median nerve injury. So median nerve deals with a lot of the flexion of the hand. So particularly the lateral side, right, the thumb side. So in that regard, you're thinking medial nerve. If they talk about a medial epicondyle fracture, that is going to be, and you could see it here, that's the medial aspect. That's going to be an ulnar nerve injury. So medial epicondyle, ulnar nerve. So then again, you're thinking about flexion, but you're talking about the medial side of the hand, right? If you're confused on the test, like where the ulnar nerve innervates, in particular the sensation, if next time you hit your elbow, right, and you feel the inside and outside aspects of your ring finger, and you could see that the feeling is lost on your pinky finger and half of your ring finger, actually. So if you run your finger along it, that's a good way to remember it. All right, and you can see that here. So how do we not get confused by radial and median in the left? Well, we're talking about extension. So the last question, if we're talking about extension, we're talking about the radial nerve. So the dorsum of the hand, sensation of the dorsum of the hand is also going to be the radial nerve. The teaching point here I wanted to make was that even though you injure the mid-humerus, your extension of the elbow, that nerve to the triceps, is intact. Okay, and again, look, so you can see here, the palm of the hand, this red area is the ulnar nerve. So next time you hit your funny bone, you're actually hitting your ulnar nerve right about the medial epicondyle. That's what you're hitting. So you could feel that middle finger, I'm sorry, the ring finger, and half of it is going to feel numb. And the other half is okay because it comes from the median nerve. All right, so this is from first aid, just a little information on the sensory innervation. All right, try this one. The fracture above the mid shaft is around the neck of the humerus. No, if you fracture at the neck of the humerus, you're going to have difficulty extending your hand. Yeah, but mid shaft and the condylar fractures, you'll be okay. Hi, Lindsey.
What's up?
I missed you.
I missed y'all too.
Y'all. All
Yes,
right.
I missed you, Brady. I missed you a lot.
Thank you. All right. On that note, okay, so this is a classic scenario they'll give you. I've never heard it any other way than this, right? Nursemaid's elbow, two parents swinging a child. This ligament is lax in the child just because they're not fully developed. Those bones aren't developed. So you get a slipping in this. And so this is what they talk about, swinging the child, and the radius slips out. You can see this here. It is painful, but as soon as you slip it back in place, if you correct it, it will the pain goes away. So just this radius just kind of slips out. So and they usually talk about it in regards to swinging the child. So if you pronate the arm, you could pop it back in place. All right, so just some definitions here. So you want to know that the radius is going to attach to the capitulum of the humerus, and the ulna is going to attach to the trochlea. Now, sometimes it gets a little confusing when you look at these on x-rays. So notice that at the elbow, the ulna is bigger than the radius, okay? And as you get to the wrist, the radius is going to be bigger than the ulna. But right here, if you were just looking at this and you were trying to identify, you know, which one's which, remember at the elbow, the ulna is going to be bigger, and the ulna is going to attach to the trochlea. So just some definitions there. A few other little things that we want to discuss that's a little tricky, that's not really covered well in the lectures. The median nerve and the radial nerve. So I'm sorry, let's just do this. The median nerve turns into the anterior interosseous nerve. Okay, the radial nerve turns into the posterior interosseous nerve. Makes sense anatomically, right? Here's the tricky part. The ulnar artery splits into the anterior interosseous artery and the posterior interosseous artery. So you may have come across some questions that make this a little bit difficult, but just some nomenclature here. So the nerves go straight across, the ulnar artery is going to split into these two. So hopefully that helps out. All right, try this one. All right, let's take a look at this one. So this is another one of those weird things you just have to work through. So we're going to do it together. We're talking about the DIP, right? The distal interphalangeal joint. So basically it comes down to what helps to flex the DIP. So that's going to be the flexor digitorum profundus. All right. Let's break this down. Okay, so this is your flexor digitorum profundus. It's very strange in that half of the muscle is supplied by the median nerve, the median nerve, and half is supplied by the ulnar nerve. Now, why does this matter? Because it is one of those exceptions. It should be a red flag in your head because, of course, they like exceptions. So the medial half is going to be supplied by the ulnar nerve, right? Digits 4 and 5. So again, if you're in an anatomical position, your thumbs are to the outside, so your thumbs are lateral. It makes it confusing. Why is the median nerve on the lateral side? I didn't make the rules. That's just how it is. So the medial half, right? So the digits 4 and 5 are going to come from the ulnar nerve, from the flexor digitorum profundus, right? So this area over here to there. The lateral side, digits 2 and 3, right? The thumb side is going to come from the median nerve, as we talked about, this anterior interosseous branch, right? Because that's what branches off. Okay, so like this is what the question was asking, right? He could not flex digits 4 and 5 of the DIP. Well, that comes from the flexor digitorum profundus, particularly the ulnar derivation of it, right? Because these split. So these two, even though it's one muscle, these two fingers, these two DIP joints are going to be innervated by the median nerve. And then the ulnar nerve is going to do the digits 4 and 5, the most medial. Okay, so this is just one of those weird exceptions. But I want to check out this too, because the flexor digitorum superficialis is going to be the proximal phalanx, right? The PIP joint. So the median nerve is going to do all of it, right? So if you look, let's go back one to the flexor digitorum profundus. You can see a median nerve injury is going to be more severe, right? Between these two, because the median nerve is going to do 6 joints versus the ulnar nerve is 2. But a lot of times, like the question previously, they talk about you can't flex the DIP of the 4th and 5th digit. It's just the ulnar nerve portion of the flexor digitorum profundus. Now, if you have an injury to the flexor digitorum superficialis, you're going to affect all 4 of the proximal joints. Okay, so just sit with these, let it stew a little bit, and you'll get that down. All right, the carpal bones, everybody loves these. So again, we talked about at the elbow that the ulna is larger. Now, as you go down the arm distally, the radius gets larger and the ulna gets smaller, okay? So you need to be able to orient yourself, especially on an x-ray like this. So first rule, if you can, find the thumb. So you know that the hand's kind of like this, right? And if you can't do that, find the radius, find the bigger of the 2 bones. The ulna doesn't even attach to the carpal bones. The ulna is wrapped up with the radius. So there's no actual attachment here between the ulna and these bones. Only the radius attaches to these carpal bones. The ulna is just kind of on the side and it attaches to the radius, helps with pronation and supination. Okay, so there's if we start thumb side, most proximal, right? You go scaphoid, lunate, triquetrium, pisiform. Start back over, trapezium, trapezoid, capitate, hamate, right? There's an easy mnemonic. Some lovers try positions that they can't handle. The dirtier it is, the easier it is to remember. So this is a good one. Yeah, so if that helps you, primarily you really just need to know 2 of these. We have questions on them coming up. But if this helps you remember, just remember the order, because you have to go thumb side proximal, 1, 2, 3, 4. Now you go back to thumb side distal, 1, 2, 3, 4, right? Okay, cool. All right, try this one. High yield definitely will be on the exam. They love this. All right, looks good. So yeah, so again, some of these are going to be redundant, and you'll see it again, like Herb Duchenne palsy. There's a kid, difficult delivery. Klumpke's palsy, he was hanging there. Annular ligament, the kid was swinging. This one's one of those fall on the outstretched hand, right? You fall on your outstretched hand. Which bone is likely fractured? Okay, and I put it in italics here. Scaphoid is the one that's fractured. It's the one that looks like a peanut. It's right here by your thumb. It's the one that's most likely fractured. You could see it here. Again, let's orient ourselves. This bone is bigger than this bone, so this is the radius, right? So then this is the thumb side. Radius is always thumb side. So you know that, so you know this is your scaphoid, okay? You can see it kind of looks like a peanut, and you can't unsee the peanut. Yeah, you're right. So you see the fracture there. There is a problem with this, and the problem is that a lot of time the radial nerve comes, the radial artery comes right around here as well. Like when you take a radial pulse, it's right around that area. So you can get an injury to the radial artery. Sometimes that's not obvious on x-rays. So you do need to get this checked out, because if you injure the radial artery in this area, you get avascular necrosis, which just means you're not getting blood supply to the area. So the cells die. Okay, now, conversely, same situation, but this one we're talking about a dislocation. All right, for sure, right? So dislocated. So the one that's most often fractured is the capitate. So I'm sorry, the scaphoid, right? And the one next to it, right? So some lovers is lunate. Lunate is most often dislocated. It's a posterior dislocation. It often pops out, right? So remember, scaphoid is fractured. Lunate is dislocated, right? Easy points on the test. Posterior dislocation. All right, let's talk about these. Want to make sure you have these straight on the exam as well. All right, so these get a little confusing. So you always define this by the distal fragment. So you have an injury to the radius, you define the dislocation by the distal portion of the injury. So if the distal fragment is angled forward, meaning the distal fragment is anterior, we're looking at a Smith's fracture. So let's take a look. Smith's fracture is here. Okay, let's do Colley's first. Okay, so let's look at the distal fragment, right? The hand, everything past the injury is distal. You can see here, this distal fragment is posterior. You can see how the hand's oriented like this. So this right down here is the anterior or the palm side. Above here is the posterior aspect of the hand, right? So this fracture, the distal segment, is posterior to the bones, all right, to the proximal segment. So it's a posterior fracture, meaning the distal fragment fractures posteriorly. So that's Colley's, okay? You always define it by the distal fragment. So you should be able to recognize these on an x-ray. So you could see here. So let's orient ourselves. Find the thumb, right? Thumb's here, so the palm's down, right? So the anterior side of the hand is on the bottom side. So then you see this distal fragment, you see the fracture here, you see this distal fragment is posterior. So if the distal fragment's posterior, you know that it's a Colley's fracture. Difficult to see here. I imagine they'd give you this view, this lateral view, because by doing that, you could see that this distal fragment is posterior. I'd hope they'd make it more clear than this. This is just the image that I found on the internet. But you could see that this distal fragment is posterior. Now, Smith's fracture, again, see the fracture, define it by the distal fragment. This distal fragment is anterior, right? Again, palm side, the palm's down, right? The thumb's down, so the palm's down. So this distal fragment is anterior. So here we're looking at Smith's fracture, just like the question asked. All right, so let's take a look here. Let's orient ourselves. Find the thumb. You see the thumb here? Palm is to the right. So you can see that this distal fragment is pushed forward. Okay, so if that's the case, it's an anterior dislocation. An anterior fracture means Smith's, right? So I think the key here to take away here is you always define it by the distal fragment. Distal fragment is posterior, it's Colley's. If the distal fragment is anterior, it's Smith's. All right, try this one. All right, let's take a look. All right, so I put this is a difficult question. It's got a couple of layers to it, but I put it on here because there's some teaching points. So if we look at it first, this point first, if it's cut down the surface of the flexor retinaculum, but not into it. Remember, the median nerve goes underneath the flexor retinaculum. It's kind of like a watch band, the flexor retinaculum, right? It doesn't stretch, okay? So if you get carpal tunnel or swelling of the tendons in the carpal tunnel, you can get compression of the median nerve. Now, but this says specifically, we cut down the surface, but not into it. So it can only be, so if we're on the anterior side of the hand, it can only be one of two things. And it's either median or ulnar. And if we didn't go into the flexor retinaculum, then it has to be the ulnar nerve. The ulnar nerve doesn't go in the flexor retinaculum. It goes anterior to it. It goes through Guyton or Guyon's canal, I believe. So that's the first thing. So we know we affected the ulnar nerve, not the median. Now, this is another tricky thing, because if you think about this, well, the ulna kind of deals with the medial aspect of the hand, right? Digits 4 and 5. What does the ulna have to do, or the ulnar nerve have to do with the thumb? Well, the ulnar nerve actually, this is one of these exceptions you need to be aware of. It actually innervates the adductor pollicis muscle. So it helps with adduction of the thumb. Okay, so even though the adductor pollicis is on the lateral side, right, typically the median nerve side, it's innervated by a branch of the ulnar nerve. So this is one of those exceptions they can throw in there and to throw you off, because you're thinking thumb side, but actually the ulnar nerve has a little branch that helps with adduction of the thumb. Okay, so keep that in mind. And then this is from first aid, but we're going to talk about this in a little more detail. All right, so median nerve. So there's thenar muscles, right? That's under your thumb. They're the oaf muscles, and they all have pollicis in it. Pollicis means thumb, right? Then you also include the lateral two lumbricals. This is another tricky thing. But remember, the lumbricals are going to are going to be the muscles to basically help the fingers do this, right? And we'll talk about that in a second. But just remember, the lateral two, the lumbricals that go to your second and third, your index finger and your middle finger, are going to come from the median, right? So you can remember this mnemonic, or if you want to try to keep those together: lateral two lumbricals and the oaf muscles. But the oaf comes up again. So remember that these oafs have pollicis in it. All right, now let's look at the ulnar one. Again, like I said, oaf comes up again, but these all have these oafs have digiti mini-me in them. A sentence you never think you'd say, right? Okay, great. And you can see that here. The median two lumbricals, and that's going to be the digits 4 and 5. So those lumbricals are going to come from are going to be innervated by the ulnar nerve. Okay, now the ulnar nerve also innervates the interossei muscles. These interossei muscles are going to help you with adduction and abduction of the fingers. Okay, adduction and abduction. So these are important because when they talk about these injuries, they'll mention the medial two lumbricals. They'll mention you can't adduct the fingers here, and we're talking about the interossei muscles. So you have to keep these in mind. So remember that the lumbricals are split. The medial two is going to be by the ulnar nerve. The lateral two are going to be innervated by the median nerve. And again, the only way you're going to get these down is to do those graze questions, right? Once you have a basis of understanding, you have to put the symptoms together to figure out what's going on. So now when we talk about the median and ulnar nerve, we typically talk about flexion, right? They're all on the flexor surface. But a little caveat is that these lumbricals, because of how they insert on the PIP, the lumbricals actually help the hand do this, right? So flexion at the MCP, but extension at the PIP. Okay, and you can see that here. So the lumbricals, remember, the median two lumbricals are going to be from the ulnar nerve. The lateral two lumbricals are going to be from the median nerve. They're going to help you flex the MCP joint, but extend the PIP and DIP joint. There's this hood that forms, and but if you just remember this, that's how they insert into these joints. So the lumbricals will help you do this with your hand. So this is a little advanced, but you're going to come across some questions that talk about it. So I just want to cover all of our bases. So we said this already, these lumbricals, these are going to be flexors, but there is an exception. They will extend the lumbricals at the IP joints, okay? Now, the interossei muscles, remember I said they're all innervated by the ulnar nerve. So we use this mnemonic, it's really easy, dab and pad. So the dorsal interossei, abduct, right? Spread the fingers out, abduct. The palmar interossei, adduct, bring the fingers together, right? So if you remember dab and pad, you'll be able to keep those together. And remember, they're all innervated by the ulnar nerve. And again, there's a central axis at the middle finger. So adduction is going to bring everything toward the middle finger. Abduction is going to bring everything away from it. Again, the ulnar nerve is what's going to innervate all of them. The mnemonic is dab pad. All right, try this one. All right, so these get a little tricky. So let's walk through it. Just a question that came up in the chat. Technically, you have oaf muscles that are innervated. There's oaf muscles on the thenar side and oaf muscles on the hypothenar side. Remember, the oaf muscles that are on the thumb side are going to have pollicis in it. The oaf muscles that are on the hypothenar side are going to have digiti minimi in it. Tongue twister. All right, good. Benediction attitude, right? So you're kind of like this, like the Pope, right? So like, you know, this is what they call benediction attitude or Pope's blessing. So the point is here, when this patient tries to flex these two fingers, he's not able to, right? So what is controlled by that? Well, that's the median nerve. The median nerve is going to be in charge. Remember, we have the flexor, the profundus and the superficialis here. Remember, the flexor digitorum superficialis is all by the median nerves. And then in these two digits, these lateral two digits, the flexor digitorum profundus is by the median nerve. And also the lumbricals too. So when he tries to put his hand together like this, he's okay on the ulnar side, but on the median aspect, or sorry, the lateral aspect, but the median nerve innervation, he can't flex the fingers, right? So that's going to be the median nerve. So this is from first aid. Again, it's one of those things you have to sit with because it depends if you're trying to open your hand or close your hand. But basically, if you're trying to make a fist, this is what the patient had, this Pope's blessing. He's trying to make a fist and he can't flex the first and second digits, right? So he's stuck in this Pope's blessing. Now, you also can say if the patient is trying to make a fist here, right? The patient's trying to make a fist and they can't flex this outer aspect, the pinky and this ring finger, then you have some sort of injury to the ulnar nerve. Now, there are also, if they ask you if they're trying to extend the hand, you also can't fully extend the hand in either aspect. Like for instance, here, you're trying to extend the hand. And the reason you may initially think this is a radial nerve injury, but remember those lumbricals help to extend the PIP and DIP. Okay, that's a little more advanced, but just in case they ask, the lumbricals are innervated by the median nerve, so you can't fully extend them. So let me just go through these one more time to make sure everybody's got it straight. If you're trying to flex the hand, right, this is what they'll probably ask. The patient tries to flex and the index and middle finger are stuck in upright, right? You can't flex them. Then that's going to be the Pope's blessing. You're worried about a median nerve injury. Now, what if they ask the same patient to extend their hand? Well, they can't fully extend either because the lumbricals that are innervated by the median nerve are also affected. Now let's talk about the ulnar nerve, the purple. If you're trying to make a fist, those median fingers, right? If you're in anatomical position, the 4th and 5th digits, they can't flex, right? Now, if you ask the same patient to extend, those fingers can't fully extend either because of the lumbricals, okay? But if this confuses you, just use the fist as an example, because that's probably how they'll ask it. But just remember, if they do ask the extension, they can't fully extend either, and that has to do with those lumbricals. All right, let's quickly talk about the thorax. For MSK, thorax isn't terribly important just because when you get into cardiovascular, a lot of the organ systems and respiratory, it's going to come back. But there are a few things that you need to know in regards to musculoskeletal, the musculoskeletal system. One is this Van relationship. So you need to get your semantics right here. So this bundle runs inferior to the superior rib. Okay, what does that mean? So you see this vein, artery, nerve relationship here, this vein, artery, nerve. It runs inferior, right, to the superior rib. So if this is the superior rib, this is the inferior rib, this vein relationship is going to run inferior to the superior rib. If you have to do some sort of thoracocentesis and put a needle in there, you don't want to go in this area, right? You want to avoid this bundle. So you always go, so if they ask you for the needle insert, you want to go superior to the inferior rib. Okay, you see what I did there? So the nerve runs inferior to the superior rib. So if you insert a needle, you want to go superior to the inferior rib. I know that's, it's just a lot about semantics, but you just need to, they can ask it either way on the exam. So to avoid the bundle, you go superior to this inferior rib, and you'll avoid that little nerve, artery, vein bundle. All right, try this one. All right, so the key here is thoracocentesis. You're trying to get fluid out. You want to go to the most gravity dependent area, which is the lowest point. It says here this paravertebral line, that's along the vertebrae, right? So you definitely want to go between the 10th and 12th, which is the 11th rib, right? So you could see that here. This is an important slide. Because they could tell you if you go mid-clavicular, typically clinically they go mid-axillary, so you go around rib 9 just because that's a convenient place for it. But the point is you want to get into this costodiaphragmatic recess, but you don't want to affect the lung, okay? So fluid's gonna collect in this costodiaphragmatic recess. You need to get in there without puncturing the lung. I wanna go back real quick. I just wanna clarify some stuff. Okay, so the question here, look at this second context, right? The context is what's important. Now, yes, the radial nerve is involved in extension. Granted, we're not talking about the radial nerve here. What I'm telling you is that the lumbricals do have a component in extension, and those lumbricals are innervated by the median and ulnar nerve. So you can't fully extend if you're trying to extend. The radial's intact, but you get this partial extension because the lumbricals can't fully extend these fingers. But so you have to ask yourself, is the patient trying to make a fist, or is the patient trying to extend their fingers, right? Either way, they're affected. But in a general sense, what they're going to ask you is when the patient tries to make a fist. So with this Pope's blessing, if the patient tries to make a fist, the thumb, the index finger, and the so digits 1, 2, and 3 are affected, so you can't flex them. If you're talking about this ulnar claw and you're trying to make a fist here, like this one right here, you're not going to be able to flex the pinky and the ring finger. Okay, so that's basically what you need to know for that. Okay, we did this. Okay, this is another thing they like to test on. Try this one. All right, so basically want to know what is the most important way. So all of these methods are ways to bring about negative pressure in the lungs. So you're sort of making a vacuum, right? So by extending the cavity, you make a negative pressure, so you bring air into your lungs. The primary way we do this, the most important way, is the descent of the diaphragm. Remember, when you contract your diaphragm, it descends, and it will help to increase the vertical dimensions, right, of the abdomen, thus making a negative pressure, and it allows you to bring air in. But you need to be aware of these different methods. There's this pump handle, which is an anterior posterior displacement. So you're bringing the rib cage up, right? Again, it still makes a negative pressure. So you're going to bring air in. You also have this bucket handle, right? Bucket handle goes to both sides. You're able to bring air in that way. So it is the lateral dimensions. But by all means, you contracting your diaphragm, this large muscle at the base of your thorax, will help to bring air in that way. All right, try this one. All right, cool. Y'all got this one. So remember, latent infection, we're talking about the herpes zoster virus. So this person had chickenpox. After you have chickenpox, this herpes zoster virus tends to hang out in the DRG, right? And if you get immunocompromised, or you know, a lot of times that happens with age, it can be a reinfection of this latent infection, right? So you get shingles. But key point here is that it kind of hangs out. This latent virus hangs out in the dorsal root ganglion. So if you have chickenpox, it's still chilling there. Can't really do much about it. So be aware of that. All right, nerve supply, dermatomes are super important. Yeah, shingles can be at any level. Yeah, for sure. Typically in the thorax, because that's where the shingles forms. And I think, let me make sure, yeah, I have a picture. Okay, so the dermatomes are important. Remember that the, it's like a strip format, right? So the sensory innervation goes around in kind of this strip layout. So there's some important points. The T4 is the nipple line, T10 is the umbilicus, L1 is the inguinal region. So if you know those, you should be good to go. You can kind of, as long as you know T4 and T10, you could kind of work out the rest, right? But what happens is, you could see here, so I would say, like if this, so you could see when the latent infection, the shingles virus is activated, it comes out in this strip format, right? So if this T4 is the nipple line, I would say the shingles virus was about the T3 level. It got reactivated. So if they ever talk about this strip-like rash that forms, it's classically shingles, right? Because it was activated in, I'd say in this case, the T3 area, right? And so you see this strip format. Usually unilateral because it comes out of one side. All right, try this one. All right, so typically when a cancer metastasizes, it'll get into the blood supply, but a lot of times it just spreads first through the lymph nodes, right? This first lymph node that the tumor goes to is called the sentinel node, right? That's the first one. Whenever a patient gets some sort of cancer, they always want to check the sentinel node to see if there's any sort of metastasis. And if there is, they keep going until they find a lymph node that's cancer-free. So what is the sentinel node we're looking at here from breast drainage? It's the anterior axillary or the pectoral. Now, the peristernal also drains. It drains about 25%, but 75% of the drainage is going to go to the anterior axillary. Okay, so, and you can see that here, the axillary node goes there, again, the sentinel node. So it's kind of like roads, right? They all go, I don't have a, let me just see. They all drain to the central axillary node. There's the anterior that comes off the pectoral, the lateral comes, and then they get to the central. And then once they come together at the central, it's kind of like a main hub, then they can go up to the apical or the infraclavicular. So remember, anterior axillaris pectoral, peristernal is not contralateral. It's just right along the sternum on the ipsilateral side, right? But this is since the anterior axillary is going to get 3/4 of the drainage, that's primarily what you're going to worry about as the sentinel node. So again, the anterior and lateral are going to come together. You're going to get to the central. If they talk about a patient that got stabbed in the back by their scapula, that's the posterior node. So it's pretty easy to keep together. They all come together at the central hub. That's the central axillary. That's where they all come. And then they all travel together to the apical. All right, and for the drainage. When we should choose, so it specifically says what is the first to receive lymph from the tumor. That's defined as the sentinel node. So if you have some sort of breast cancer, it's going to go to the anterior axillary node. I don't have a specific chart for breast drainage. Maybe check Netter's or Lindsey might have one. And just one more point before we take a break. When somebody does have this breast cancer, if they have to take out some of the lymph nodes because they're worried about some sort of metastasis, remember lymph has to do a lot with drainage, a lot with fluid drainage. So if you take out those lymph nodes, you could be at risk for lymphedema because a lot of this swelling is due to the fact that the lymph wasn't properly able to drain. Okay, so yeah, and the anterior axillary is the sentinel node for some sort of breast drainage. So the question was asking if she had breast cancer, if it metastasized. The first place it's going to go primarily is the anterior axillary node. Okay, so that's the sentinel node in regards to the breast cancer. All right, let's take a 5-minute break. I don't know if y'all have had Dr. Trotz's 30-second break yet, but this is one of her slides since everybody loves her so much. So we'll take a 5-minute break. We'll come back, we'll cover everything, the lower body. So let's do that. All right. We could go ahead and get started. Okay, I just want to make sure this was clear from earlier. If you have some sort of herniation in the cervical area, so let's say C2 and C3, remember the nerve that's affected is the one below, so C3. In the thoracic region, if you have some sort of herniation, say between T2 and T3, remember the nerve above is what's going to be affected, T2. It's in the lumbar region, between L4 and L5, the nerve that will be affected is L5. So it's in cervical, it's lower, lower nerve. In thoracic, it's the upper nerve. In the lumbar, the one that's affected is the lower nerve. Because y'all will have a question or 2 or 3 on that. So I want to make sure that's straight. Okay, let's take a look at the pelvis. Go ahead and try this question. All right, so I'll put this in here. There's an easy way to remember this. So remember the fascia from the abdomen is going to come down into the pelvis and help to make particularly like the areas of the scrotum. So the transversalis fascia is what comes here. If you, oh, there it is. Okay, and you can see it here. So like I said, the fascia from the abdomen comes down and helps to make the layers of the scrotum. And you can see here, this is the easy way to remember it. So ice tie, ice turns into tie, right? So internal spermatic fascia turns into the transversal, or I'm sorry, the transversalis fascia turns into the internal spermatic fascia. The cremaster muscle comes from the internal oblique muscle. The external spermatic fascia comes from the external oblique. Okay, so ice tie, easy way to remember that, easy points on the test. All right, try this one. All right, so make sure you know these because they could ask you this in a number of different ways. But the deep inguinal ring is going to be the internal, it's going to be an indirect inguinal hernia. Remember, the direct inguinal ring, the direct inguinal hernia and the indirect inguinal hernia will go through the superficial ring, but only the indirect goes through the deep. So if you think about it, let me see if I have, I think I have a, yeah, so indirect comes from outside. So the way you can define this is indirect comes lateral from to the epigastric vessels. Direct comes medial to the inferior epigastric vessels. Very important. But remember, since indirect is on this lateral side, it has a longer route to take. So it has to go through the deep ring and the superficial ring. The direct hernia just goes through the superficial ring. So remember, you can they can ask you, it comes from it comes out laterally to the inferior epigastric vessels, or it comes out medial to it. It's a good way to tell the difference. Also, direct hernias are typically some sort of mechanical injury, some sort of strain, whereas indirect hernias are usually congenital. So like a patent processus vaginalis, right? But again, since it's indirect, it has to take a longer route. It passes through both the deep and the superficial rings. So make sure you keep those in mind. Try this one. Whoops, I didn't mean to show y'all the answer. Anyway, this one's pretty straightforward, just asking you where McBurney's point is. You have some sort of appendicitis, you could, and you're trying to locate McBurney's point or where the appendix is. It's 2/3 the distance from the umbilicus to the anterior superior iliac spine. So you can see here, 2/3 the distance from the umbilicus to the anterior superior iliac spine. That's where you'll find your appendix. Okay, this is just a concept I wanted to touch on. I don't have a question on it, but remember, this arcuate line is important because the musculature that goes, when you're above the arcuate line, the internal oblique, half of it, and the transversalis fascia goes below the rectus abdominis. Once you go below the arcuate line, like a point by the medial umbilical ligament, all the muscles and the aponeurosis that connects them goes in front of these rectus abdominis muscles, okay? Just a point in case y'all come across it on a Gray's question, this is one of the important points of this arcuate line. So above it, some go behind, half go behind and half go in front, and below it, everything goes out in front. Okay, try this one. So this is, yeah, this is more, yeah, this is abdominal. Yeah, abdominal pelvic together. Okay, so you have to be careful here. There's an afferent branch and there's an efferent branch. Afferent is going to be the sensory aspect. That's going to be ilioinguinal. The efferent limb is going to be the genitofemoral branch. Okay, so it's going to be the genital branch of the genitofemoral nerve. That's going to be the efferent branch that helps to lift the testicles with this cremaster reflex. The ilioinguinal is going to be the afferent or the sensory aspect. Okay, so you could see here, just to kind of point out, the ilioinguinal is the L1. It has that, goes through the inguinal canal. Iliohypogastric goes a little bit above it around the area of the kidneys. Genitofemoral is L1, L2. So you could just kind of make sure you know these just in case you get a question on those. We discussed the cremaster reflex, ilioinguinal, and the genital femoral nerve. Okay, let's try this one. All right, so what we're asking here is what's the collateral circulation, right? So you have a complete occlusion of the inferior vena cava. So how are you gonna get blood from the lower body up through back up to the venous system? So the ascending lumbar is gonna be the vein that connects this common iliac vein to the azygous system. So this is an additional pathway if for some reason your inferior vena cava is occluded. And this is kind of a crude drawing, but you can kind of see the azygous system. Accessory hemiazygous is going to be on the left side, and you can see the azygous comes up here. You can see, so just an additional drainage system from the caval system back up through the back up to the right heart. All right, try this one. All right, so relaxin is going to help to obviously relax those muscles around the pelvis to allow a vaginal delivery. Remember, the true conjugate diameter is what's not going to change. It's the true diameter. This anterior posterior axis doesn't change. That's this right here. So all the other muscles will help to relax. This may, I don't know when y'all would have learned this. This is one, I'm pretty sure it was a Gray's question. So this true anterior posterior diameter will not change. So keep those in mind when you do this. There's also the interspinous diameter. That's going to be your narrowest angle. Okay, so you have to keep that in mind when you have a vaginal delivery. They can measure the fetus's head and make sure that have a proper, they'll be able to have a proper delivery. All right, try this one. Okay, so whenever we're talking about this fecal incontinence, right? We're talking about that the muscles around the rim. And so you have this, it's primarily this pubococcygeus muscle. So you can see here around the anus, you have this pubococcygeus. Sometimes they talk about this little part, it's called the puborectalis. Technically, they're all kind of together. So this pubococcygeus muscle, if there's some sort of injury to this muscle, it could lead to some sort of incontinence. Here, primarily fecal incontinence, but I imagine you can get some urinary incontinence as well with this. But in regards to what y'all are doing right now, I would primarily consider it fecal incontinence. A lot of times urinary incontinence has to do with some sort of internal factors, but y'all will get into that when y'all do renal later on. All right, try this one. It could either be puborectalis or pubococcygeus, but they won't put both in as an option in a question stem or answer choices. All right, good. So when we talk about this Trendelenburg sign, or it tends to be like this offsetting of the hip, right? So I put this in here because it's not exactly intuitive. You have to remember that if you have the gluteus medius and minimus on the right is going to help hold the left hip stable, okay? So if you have an injury on the right and you lift your left leg's gonna drop down. And that's because the muscles on the right can't keep the hip up straight. So just remember, they could put this on the test. It's not exactly intuitive because it's left hip, but it's a right-sided injury. So that's referred to as a positive Trendelenburg sign. So be aware of that. You could see that here. So same situation, right? We said right gluteus minimus and medius injured here. You try to lift that left hip and your left hip's gonna drop. So that's a positive Trendelenburg sign. All right, let's go into the lower limb. Try this one. All right, now I will post the PDF with these explanations later on today, but you have to be careful because you have to look at the age here. So I'm going to read it to you what it says. An infant or child about the age of 8 years, the head of the femur gets its arterial supply by a direct branch of the obturator artery, okay? But this patient's elderly, so it's actually going to be the ascending branch of the medial circumflex artery. So whenever you have some sort of avascular necrosis, right, which means decreased avascular, no blood supply causing necrosis to the femoral head, you're worried about this medial circumflex artery. Okay, it's going to be what gives blood supply to this I think retinacular, is that how you say it? Reticular arteries. They're the little arteries that go around here, but this medial circumflex artery is what is going to be supplying it. But again, if it's a young child, they could ask you about it. That's going to be a direct branch of the obturator. But again, that's going to be obliterated later on. So in an elderly patient, you're worried about, or in an adult patient, you're worried about this medial circumflex artery. Now, we talk about this, and you can see that Shenton's line should be straight across, right? You see the femoral neck, femoral head, and so this line should be straight across right here. If you have some sort of injury, you see the fracture here. This decreased angle indicates a fracture, but look at Shenton's line, it doesn't go straight across. So that would indicate a fracture. And so we're worried about this medial circumflex artery, right? You want avascular necrosis to the femoral head due to compromised blood supply from the medial circumflex. All right, typically these intracapsular fractures are much worse because you do get the avascular necrosis. Extracapsular, while not good, are better than intracapsular. Okay, again, intracapsular, avascular necrosis. Yeah, there are retinacular arteries, right? So that medium circumflex is going to give blood supply to these little retinacular arteries, which supplies the femoral head. So keep that in mind. All right. Now, before this is over, y'all will be able to identify the ACL versus the PCL on MRI. So remember, the anterior cruciate ligament runs in front, the PCL runs behind, okay? So the anterior helps to prevent anterior displacement, the posterior helps to prevent posterior displacement. Straightforward. So let's answer this one. Yes, so just a question. Yeah, so an injury to the femoral neck will give compromised blood supply to the head. All right, good. So injury to the anterior cruciate ligament prevents anterior displacement. So this positive drawer sign means it's being displaced anteriorly. So think about it. If you put your thumbs on the patella, right, and you put your fingers behind the tibia and fibula, and you're able to pull like a drawer, pull the lower aspect, the tibia and fibula, forwards. That's an anterior drawer test. That means it's sliding anteriorly when it shouldn't. That means the ACL is compromised. The ACL is supposed to keep it from sliding anteriorly. Okay, so ACL anterior drawer test. Okay, you could see that here, right? So imagine putting your thumbs on the patella and your fingers behind the lower leg and being able to pull it forward. This ACL should be preventing you from pulling it forward. Again, posterior drawer set test, same thing, but instead you're pushing the tibia backwards, right? So with that, if the PCL is intact, it'll prevent you from pushing the tibia backwards, right? If you can push it backwards, that's a positive posterior drawer test. Maybe the PCL is injured. So you could see that here, same principle. If you could slide this forward, it's tibia, fibula, ACL tear. Posterior is a PCL tear. This helped me kind of lay it out, and we're going to look at some MRIs in a second. So the ACL is this red line. So you could see if you're pulling the lower aspect of the leg forward, this red line is going to prevent it, right? So that means the ACL is intact. If you try to slide the tibia backwards, this blue line would prevent it from moving. That's the PCL. So keep this in mind, and we'll look at this. So little difficult at first, but what I did was I outlined it for you. So you could see this is the anterior cruciate ligament, right? You kind of see it dark there. They won't put an image. I don't think they'll put an image where you could see both the ACL and PCL. Like everything I've seen in the lectures, you could just basically see one. So you see the ACL, it starts posterior on the femur and ends up anterior on the tibia, right? So if it moves anteriorly, it prevents anterior displacement. So that's the ACL, right? Starts posterior and ends anterior, just like this picture here, right? Like this. You could see that here. Now, PCL, this one's a little more apparent. You can see I outlined it here. So it starts in this aspect and it ends on the posterior aspect of the tibia, right? So it moves posteriorly. It prevents the tibia from moving posteriorly, right? So you should be able to identify those on an MRI in case they give you that. All right, try this one. All right, so this is a classic situation. It's usually some sort of sports injury here. A player, the defender, hits the player, the wide receiver on the lateral aspect of his leg. So this is typically, it's called the unhappy triad. So what happens here is these are often injured together. Now, some people say the unhappy triad includes the medial meniscus, some say the lateral meniscus. Either way, the unhappy triad includes the MCL, the ACL, and either the medial meniscus or the lateral meniscus, right? So here, with this injury, this blow to the lateral aspect of the leg is going to affect the ACL. And you could see that here, right? So if you hit the player there, you're going to end up stretching it and tearing the medial aspect, right? Because that's what's going to be stretched when you do that. So those kind of go together. So keep those together in your mind, because they could ask you some sort of injury. They could give you two and say what is also injured, and you'll know those. Just to point these out, there are different bursas: suprapatellar, infrapatellar bursa. They do talk about this, excuse me, this housemaid's knee versus clergyman's knee. Think of a housemaid as more leaned over, trying to scrub the floors maybe. So you're thinking about more of this, the subcutaneous prepatellar bursa right here, whereas the clergyman is kind of leaning back on his knees, he's praying. So you think of this subcutaneous infrapatellar bursa here. Baker's cyst, if you come across that, that's in the posterior aspect of the knee. Those can form. Okay, a couple of things to memorize, just like the upper limb. We want to remember this. Valgus, whenever you look at these, you're always worried about the distal fragment. So it's kind of like Colley's and Smith's fracture. So you're worried about the distal fragment. So for valgus, the distal fragment displaces laterally. For varus, the distal fragment displaces medially. So if you have these, the coxavara will be a medial displacement. So the distal fragment is going to be the lower aspect of the femur. It's going to be displaced medially, right? So you end up with like knock knees, right? In this instance. And if it's valga, it's going to be the lower aspect of the femur is going to be displaced laterally, okay? Genu's the same thing. Varum, so now the point we're looking at is the knee. So the distal fragment from the knee is going to be the tibia. So if the tibia, you can see here, is displaced medially, right, from the knee, so that's varum. If the tibia, the distal aspect of the knee, the tibia, is displaced laterally, that'll be valgum, okay? Keep those in mind. Same thing, if we look here, we're looking at from the point of this joint here, and so we see this, the large toe is displaced laterally, so that'll be valgus. And if the distal toe, the big toe is displaced medially, right, to the medial aspect of the body, that'll be varus. So always use the distal aspect again. All right, try this one. All right, before we go through this, Nicole has a good mnemonic for this. So valgum makes your knees stick together, and varum makes your knees spread apart. So gum makes them stick together. That's a good way of remembering. But keep in mind, we're talking about the distal fragment, but thank you for that. All right, so here we're talking about how would you get collateral blood supply past the knee? So remember, when did we talk about the medial femoral circumflex? That's when it with an injury up top, with an injury to the femoral neck, right? So we're worried about compromised blood supply. When we're talking about the lateral aspect of the knee, we're looking at the lateral femoral circumflex. So those are both important for two different reasons, right? Medial's up top, laterals towards the knee. So keep that in mind. And you can see these anastomoses here, a lot of blood supply there. So the lateral artery is going to help keep the blood supply going in that case. If you're trying to orient yourself here, remember the fibula, the small lower leg bone is going to be always on the lateral side, okay? So that's that. Try this one. All right, so quickly, just to reiterate, the lateral femoral artery, it runs down around the knee, so it does give a collateral blood supply if there's any sort of compromise. I will post these answers later so y'all could get a more full understanding and you can go through those. So let's see here. Okay, so again, we are not asking what that nerve does. We're asking if there's an injury, how would the patient present, right? So remember, the tibial nerve runs in the posterior aspect of the leg, right? Like your calf area. So it's responsible for plantar flexion primarily, but also has a component of inversion. So if you take away plantar flexion and you take away inversion, the leg will be dorsiflex and everted, okay? Now, D would be what the actual nerve does, okay? E is how the patient would present, okay? So again, keep these in mind when you take the test. Those are easily mixed up. So if we look at the different compartments, the anterior compartment is here. It's going to be primarily innervated by the deep fibular nerve. The lateral compartment, it'll be the superior fibular nerve. Its only really job is eversion. And then the posterior compartment, like we just talked about, is the tibial nerve. So both the deep fibular nerve and the tibial nerve both play a part in inversion, right? And like we mentioned earlier, tibial nerve will help with plantar flexion. Deep fibular nerve will help with dorsiflexion. Both of these are going to help with inversion. Okay, try this one. Okay, so this is a tricky question. So we need to find out some data here. Because remember, we have to find the proximal point that includes all of the components, all of the symptoms. So, and I put this on here for a reason because it's a good teaching point. So there's a pronounced left foot drop, right? So that means that patient can't dorsiflex the foot. That's going to be your deep fibular nerve. So we know that's included. But if you keep looking, you get sensory loss over the dorsum of the foot and the lateral leg. Sensory innervation of the lateral leg and dorsum of the foot comes from that side, the superficial fibular, right? So if we have both of them affected, as it stands, they come from the same nerve, right? Right around the lateral aspect of the fibula, which is a common place that's injured, right around the knee at the top of the fibula. The most proximal part of the fibula is where the common fibular nerve is. Then they split apart into the deep fibular and superficial fibular. So key point here is you have to look at all the symptoms because it includes both of these nerves. So the most likely answer is that you injured them before they branched off, okay? So good point to learn there. Again, that common fibula runs right around the head of the fibula, right around the knee. All right, try this one. All right, let's take, excuse me, a look at this. So the tarsal tunnel is synonymous with the carpal tunnel in the hand. Again, we have this flexor retinaculum, right? So remember we talked about the carpal tunnel. If you get, that median nerve goes underneath it. If you get swelling of those tendons, that band, that flexor retinaculum can compromise the innervation or pinch that nerve, and you can get carpal tunnel syndrome. The tarsal tunnel is very similar, except it's around the ankle. It has this band of tissue, this flexor retinaculum down there. So the key thing here is this tibialis posterior tendon goes through it, and this is where you want to remember this. Tom is tibialis posterior, Dick, and very, very nervous Harry. You could see this here. And that's how they run through the tunnel. I think, I have a better picture here. So you could see them here. This is that flexor retinaculum here, this tarsal tunnel, and they run in the same order. So from anterior to posterior, it's tibialis posterior, flexor digitorum longus, artery, vein, tibialis nerve, and then the flexor hallucis longus. So you could see that here, how they run anterior to posterior once they go through that, the tarsal tunnel. So this is from first aid, just kind of shows you where the dermatones are affected sensorily for your, and you can see here where these, because they kind of cross over from lateral to medial. So you can see that here, you kind of want to know where the sensory innervation is, just in case. So this L4, L5 will come to the median aspect. This L4 will actually come all the way to the big toe. So that's often compromised. You'll see people talking about, clinically talking about weakness or numbness in their big toe. That's because their L4 nerve is injured or is compressed. And we know that L4 will be compressed between the L3, L4 junction. Excuse me. Sorry about that. All right, so compartment syndrome is where you get increased pressure, okay? So you have to release this deep fascia. The fascia doesn't really expand. So if you get some sort of blood pooling and these muscles begin to swell, they swell to the point where you can't get any sort of drainage. The pressure's so high that there's no drainage of any arteries or veins. So it's an emergency. You get the 6 Ps, pain, paresthesia, pallor, paresis, pulselessness, and poikilothermia, which is coldness. But it just basically means the pressure's so high that it's squeezing down on the vessels so that you can't get any blood flow through it. So you have to actually cut this fascia and alleviate the pressure to regenerate the blood flow. All right, bones of the foot, kind of need to know these: 7 tarsal bones, 5 metatarsals, 14 phalanges, okay? So we're gonna do some questions with it, but quickly, we'll look at these particularly in regards to ankle sprains, okay? So this plantar calcaneonavicular, it helps to make the arch of the foot. It's your spring ligament. That's an important one. But if we look around on this, the lateral side of the foot, this anterior talofibular and this calcaneofibular are really important with sprains, inversion sprains. So with that being said, try this question. All right, so remember, because it may not be intuitive, if you have an inversion sprain, right, your foot is turning inward, you stretch the tendons on the lateral aspect of the foot, okay? Just like with an eversion sprain, you're stretching the medial ligaments. So here we're talking about an inversion sprain, which is classically what you think of when if you sprain or twist your ankle, your foot turns inward. So you're stretching the lateral aspect. So here, from the options provided, the calcaneofibular is the one that we're talking about. It's the one on the lateral side that's stretched. But this one wasn't included, but the most commonly torn one is the anterior talofibular, connects the talus to the fibula, right? And calcaneus to the fibular. So you can use those to your advantage. The names are pretty simple. So those are the two that are affected when you have some sort of inversion sprain, anterior talofibular and calcaneofibular. This is from first aid, just kind of points out the different injuries. Remember that calcaneofibular is the most distal running. It connects the fibula to the calcaneus. Okay, so let's look at these. These are just the muscles of the foot. I didn't find that these were tested as heavily as the muscles of the hand and the upper limb, but you do want to know them. The lath muscles here are the ones in red. So you can see that those are innervated by the medial plantar nerve. So remember that here in red. Now, you could use the same mnemonic that we used for the hand, for the foot, the pad and dab, right? So dab is for dorsal's abduct, right? They're going to spread the toes apart, and pad is for dorsal's adduct, okay? So these are going to be innervated by the lateral plantar nerve, okay? So that's synonymous with the ulnar nerve in the hand. So it's going to help spread the toes and adduct the toes and abduct the toes and adduct the toes back together. All right, varicose veins. This tends to happen in elderly people, and it just has to do with these valves. These valves become compromised, and sometimes the blood flow can get into the more superficial veins. And when that's the case, you get this backlog of blood. So you could see this swelling, this venous swelling, because you can't get the blood back up to the heart, right? So this is a very gravity dependent process, but it has to do with these compromised valves. All right, and just to show you these dermatomes again, really important. L1's the inguinal area. So you go down, you see L5 goes to the medial aspect of the toes. L4 will cover that big toe there. And then again, this is from first aid. I would put a star on this slide. You kind of know the T4 we talked is the nipple line. These are dermatomal landmarks. T10 is the umbilicus. S2, 3, 4 keeps the penis off the floor. Easy to remember there. Nice little mnemonic. L1 is the inguinal region. L4 down on all fours because L4 is on the knee region. So they pretty much go straight across, but remember in the legs, they cross over like this. So just keep that in mind. But remember L4 is over the knee. L5 will cover the big toe, right? Okay, reflexes, just in case they ask. Achilles, you think S1. Patellar reflex is typically L4. Biceps is C5. C5, C6, remember the mnemonic C5, C6, pick up sticks, right? So you use your biceps to pick up sticks. C7, C8, lay them straight. Triceps to lay them straight. That's that reflex. Cremaster, we talked about that. Remember, L1, the sensory aspect of the the afferent branch is the ilioinguinal. The efferent branch is the genitofemoral, okay? And then the anal wink reflex, remember we said S2, 3, and 4. So that keeps the penis off the floor. It's also your anal wink reflex. So it's a good mnemonic to remember that. All right, try this one. All right, so this is one of those weird things, but they like they like to test on. That first web space is always, if you see that red flag, it's always deep fibular. So you can see that here. You see this little yellow spot right here. So if you drop a knife in between the web space in between your first and second toe, that little bit, just that little bit, is innervated by the deep fibular nerve. Okay, so they just like to test on it. But again, this kind of lays out where everything goes, medial plantar versus lateral plantar. Sural's on the outside, saphenous is on the inside. But they do like this first web space for whatever reason. Remember, that is deep fibular nerve. Okay, and you can see it again here. See this little yellow space? That's the only place that is for the sensory aspect that's somatic afferents, that's innervated by the deep fibular. So that's that. Okay, almost done. Quickly, I want to go through. Wait, let me just clarify. Did y'all do this yet?
Yep, we did this
Yes.
yesterday.
Yeah.
All
that was the
right, so
second lecture.
we will just touch on this real quick. And then I believe Lindsey's going to have some extra questions for you guys too. Can I get a confirmation on that? 10-4? I'll take it. All right. So again, with this development stuff, this embryology, keep it clinical. All right. The questions they're going to ask are clinical. I would do the embryology section of the greatest questions. Don't forget those. Those are clinical questions. So when we talk about these somites, 3 derivatives, sclerotome, it's going to be vertebrae and ribs, myotome, myo meaning muscle, dermatome, like we talked about, connective tissue, and the dermis, right, the skin. So those are some good definitions to know. I would highlight this slide, put a star on it. They like this. This proximodistal aspect has to do with this AER, this apical ectodermal ridge. These are important because we're going to look at the clinical aspects of it. Anterior, posterior, this zone of polarizing activity. It's the Sonic Hedgehog gene. I don't know if y'all remember the game, but Sonic Hedgehog has a mohawk. That's how I remember it's anterior, posterior. It helps if you have a problem with Sonic Hedgehog. A lot of times, I guess I don't need to know this, but you can get holoprosencephaly. You don't get two hemispheres of your brain, right? That helps me remember it too, because it helps to control this separation, this anterior posterior separation. So dorsoventral is going to be this this dorsal ectoderm and ventral ectoderm. So just keep these in mind. They could ask you stuff, but they'll probably ask you in a more clinical aspect. All right, so week 4, limb buds development. That's probably the most important point to make here. But you do get these hand and foot plates in week 5. The digital rays or the fingers start to form. Remember, originally we all had webbed fingers, right? Like Aquaman. But apoptosis, right? So controlled destroying of those cells, right? This programmed cell death is the proper term for it, will cause these webbing of the fingers to go away to apoptose. And then you're going to actually have fully formed fingers. So primarily this week 4 is the most important point. So y'all are going to get into this next week, a lot of the bone, so I won't harp on this, but this appendicular skeleton or these long bone formation has to do with endochondrial ossification, but we can leave that for later. Yeah, but go ahead and try this question. All right, good. So we kind of mentioned this earlier, this incomplete apoptosis of the tissue between the digital rays. So that's going to be the important point. So this is classically called syndactyly, right? The combination or the joining of two digits, syndactyly. So you see here, this primarily has to do with this zone of polarizing activity, which we mentioned here, which has to do with Sonic Hedgehog. So syndactyly, that's what you're thinking of. You can see that here. They could ask you the differentiation. Cutaneous syndactyly is going to be the webbing of the fingers. Osseous meaning bone. You can actually get bones to fuse. But syndactyly, you're thinking of some sort of problem with the Sonic Hedgehog gene. Polydactyly, poly meaning extra. You have this extra digit. Again, it has a problem with this anterior posterior pattern. When we think anterior posterior, we think Sonic Hedgehog. Clubfoot or Telepidus equinovarus. Sounds like Harry Potter, but all right, so that's clubfoot. They could know both names for this because they could ask you either way. All right, try this question. All right, whereas amelia is complete absence of the limbs, Meromelia is shortening of the limbs. So if one limb is shorter than the other, it could be meromelia. There are some drugs, y'all don't really get into that just yet, that can end up causing this. So we could see those here. Amelia is no arms, and shortening of the arms can be meromelia. Club hand and club foot, ectrodactyly, you can see that here. So this is failure of development of the digital rays. So sometimes, I don't know if this is really politically correct to say this anymore, but it's referred to as the lobster claw deformity. So you can get a partially or completely fused or absence of the digits. So keep these are kind of close together, but keep these separated. Amniotic band is a mechanical problem. So it just happens in utero. You get the amniotic band cuts off blood supply to either a limb or a digit, and this ring constriction will cause pathological amputation of the leg, right? Okay, and then lastly, this is one of those weird ones, this Vactral syndrome. This is what Vactral stands for. They don't really seem intuitive that they would go together, but if you see some of these symptoms, I believe you only need 3 of them to classify as Vactral syndrome. If you see any of these together, 3 or more, it has to do with a problem embryologically. So they go together: vertebral defects, anal atresia, cardiac defects, that TEF, tracheoesophageal fistula, renal problems, or limb problems. So if you see those, it could be related to this. And that's all I have for you guys. I will post the PDF with explanations for all of the questions, more full explanations later on today. So look out for those. And with that being said, I will let Lindsey take over.
You are going to need to give me host access.
I don't know how to do that. How do I
Go
do
to
that?
participants, hover over my name, click more, and you can say make host.
All right. Make host. Co-host, or how does it matter? I'll just
It
make you the
doesn't
host.
matter.
All right.
Okay, cool. Okay. So before I get into this, I just want to very quickly, Brady probably did this at the beginning of his presentation. I'm sorry I was late. We had SGA e-board that went over. My tips and tricks, I mean, you guys are 2 weeks in, but because I've had a lot of people reach out to me kind of stressed about MSK, because FTM to MSK is a very different beast, and it is. The biggest thing I want to emphasize, there's no shortcut to getting all this stuff down. And a lot of people are kind of asking for that shortcut. It's like, hey, what can I do? It's like, honestly, it's just repetition. And something that I did a lot is draw on myself. I took a Sharpie, I took dry erase marker, and I would draw the muscles, the nerves, and I would sit there and I would close my eyes and I would like point it to it. And I was like, okay, this muscle does this, it's innervated by this, and like, you know, the compartments and all that stuff. So there's really no big shortcut or trick to that. It's really just memorization. And then, of course, Gray's questions, which I have been preaching ever since you guys finished your FTM2 exam. Another thing, Brady briefly touched on the embryo, because you guys are starting embryo. Now that you are systems-based, please pay attention to embryo. But if you've looked at my MSK kind of general advice on my Google Drive, I kind of outline how I approach embryo. And just like Brady said, and I want to emphasize this, it's pathology based. It is not week 1, week 2, week 3 based. It is not this happens here, this happens here, this happens here based. It is pathology based. So what I do, I go to the end of the lecture. I memorize all of the pathology, and then I work my way backwards to find out what comes from what. And so that is going to be the best use of your time, because about 85% of your embryo questions are going to be what can go wrong, and the last 15-ish% is going to be what comes from what. Honestly, you could even say 90-10 in that instance, but that's my advice for you. Blood supply, it's all about anastomoses. Do not memorize each individual artery that goes to each individual muscle. It's all about anastomoses and collateral flow if there's an injury to an area. And then, of course, lymph, make sure you know all lymph. So I know you guys have the white coat ceremony really soon. Like we said, this is recorded. And so I'm going to go through all of my questions. I'm going to try to do it pretty quickly. But again, you guys, this is recorded. And so I'm going to explain the answers to these questions. You guys can go back to the recording, but we want to respect your time. So just if you need to leave, don't hesitate. We're not going to be offended. Congratulations on your white coat ceremony. It's a big thing for you guys, but I'm going to give you guys about 30 seconds per question for this, but this kind of is comprehensive. And I apologize if there's something in here you haven't gone over, please let me know. Because the order of your stuff was actually changed significantly from the fall. And so I tried to go through all of my resources and find the questions that pertain to what you guys are doing now. Okay, we kind of have a split. I'm gonna advance in 5, 4, 3, 2, 1. It's actually suprascapular. So if you are, so this is damage to the axillary artery, and so you're asking about the anastomosis. So when you go through here, the suprascapular artery is going to be the one that is going to provide collateral flow to the rest of the limb if the axillary artery is injured. So these are the 3 involved. Please know all 3 of these. All 3 of these are fair answers on the exam. I'm going to read this because there are a lot of abbreviations. Brought to the ED via EMS with a gunshot wound to right upper anterior chest. Sono is just an ultrasound. Yeah, most of you guys are getting this. It's costodiaphragmatic recess. I don't believe I have an explanation slide. Oh, I do have my explanation slide. Okay, cool. So between the points, you want the costodiaphragmatic recess. The reason being, this is where you are going to be least likely to puncture the lung. So it's the space between the lower border of the lung and then the pleural membranes. And so you have this space where fluid can collect. And this is where you want to aim so that you can drain the fluid, but you're not puncturing the lung. You're not damaging any structures surrounding it. And that's status post appendectomy in the right lower quadrant of the abdomen. Suspect infection, sends her home with a course of antibiotics. Okay, advancing in 5, 4, 3, 2, 1. Okay, superficial inguinal. So if we are talking about, so this appendectomy, this is going to be right lower quadrant. So above and below the umbilicus, this is going to be below the umbilicus. So superficial inguinal lymph nodes. Remember, this is just cutaneous drainage. So this is the incision from the surgery. So this is cutaneous. So that's why we're talking about this. So it's cutaneous drainage and then above or below the umbilicus. That's how you can figure that question out. Correct. These are not currently in the PowerPoint. I am going to post them as soon as we are done here. Okay, gonna advance. So it is direct. I remembered this because I just I put the letters together. So direct is medial, so DM. That's how I remembered direct versus indirect with respect to medial. So I mean it's and then indirect is lateral. So I usually use really simple, corny acronyms, but it helps me because like DM, direct is medial, IL, indirect is lateral. So anything, any little weird trick helps you remember it. There's kind of a spread, which is fine. I believe there are a couple questions in grays that ask this question. But we're kind of between the two, and one of them is the correct answer. So it's ischial spine. You will palpate the ischial spine, and that's what you're going to use as your landmark to do the perineal block. Okay, yeah, this really stuck when Brady was talking about it. Most of you are getting this. So it's going to be displaced posteriorly. The distal fragment is displaced posteriorly. So please remember the difference between these two. They can, oh, I thought I put the picture in. They can use any term that is associated with this. So Colles fracture, I think there's another name for it. I don't know. But just make sure you know all the terms for each of the injuries. If it's a named injury, sometimes it won't be named, but if it's a named injury, make sure you know all of the terms. Yeah, that's what I'm talking about, the dinner fork or whatever. But just know all types of ways they can call it. I got burned once because, and I'm still salty about it. So you guys are kind of between the two we talked about earlier, which is fine. Most of you guys are honing in on it though. So you want to be superior to the upper border of the rib. And this is not how it was. This is not how we phrased it earlier in this review. I took this wording straight from Gray's. And so make sure that you understand this concept so that any way they word the answer choices, you can get it. So here you need to zero in on superior border. So superior border, upper border of the rib, because the inferior border of the rib is always going to have the artery, nerve, and vein, nerve, artery, and vein, the NAV. And so just please make sure that no matter how they phrase this, what terminology they use, you understand it so that it doesn't trip you up. So presents to the ED for right knee pain following a ground level fall 30 minutes prior to arrival. On exam, she has tenderness to palpation, no decreased range of motion. Most of you guys are getting it. It's the fibula. So please make sure that you understand which bones are involved in the joints, because these can be easy test questions if you understand this. So in the knee joint, it's articulation between the fibula and the femur and the tibia. I can't talk. And the patella and the femur, but the fibula is not involved in this. That it has a very small. If you were able to be in anatomy lab and play with all the bones, you would see that there's a groove where the fibula actually kind of nicely nestles into the tibia, but it is not actually involved in the knee joint. Yeah, you guys are getting this one. Anterior compartment of the leg. This helps you study a lot. I love to chunk information, and this kind of helps you chunk the information. And so what I would do, I whiteboarded it out and I would draw these slices and I would divide my whiteboard, and then I would list all of the muscles in the anterior compartment, posterior, lateral, and I would make sure that visually I could understand and study it like that. And then of course I drew on myself to make sure that I knew exactly where everything was. Make sure that you understand the nerves that run through, when it branches off, and when it sends its innervation to the individual muscles or the compartments. Yeah, you guys are getting this one correct. It is hallux valgus. So hallux means toe. Genu, you're actually talking about the knee to hip relationship. But hallux is going to be the toe. Valgus, remember, that's going to be, I always, the example somebody gave in the chat, the valgus gum, where the joints of the two limbs actually touch. That's how I remember valgus. And so it's not the technical description of what's actually happening, but it helps me remember it. It helps me remember it. So if that helps you, then you can use it. Okay, so this one is popliteal. Now the lower limb gets kind of weird with some of the lymph drainage, so please make sure that you understand where it goes to. Again, it's the first lymph node, the sentinel lymph node that we're referring to as in MSK. They are not going to ask you like the course of it, just the first lymph node. So superficial drainage of the lateral foot will go to the popliteal lymph nodes. And then understand superficial versus deep. So again, we're talking about a suture. We're talking about an incision site that's very superficial versus deep drainage. So that would be more structure related, not cutaneous related. That is right lower quadrant, and then PE axis physical exam. Yeah, you all are getting this. This is McBurney's point. Anytime you're talking about an API, you're talking about McBurney's point. Make sure that you don't always, you may get an API question, but make sure that you understand all of them too. So a trap that people fall into, and I do this too, I'm not immune to it, is you learn a concept and you learn the most talked about aspects of that concept, and you tend to not pay attention to the lesser examples or the exceptions. If it's an exception, you should 100% know it because that's very testable, but also the not so in your face examples. And so McBurney's is an in your face example. We all know it, it's easy, but make sure you understand all of the others too, because they'll throw an API in there, but they'll probably throw something else in there too. So don't fall into that trap. But this is just the slides that are associated with that. For those that are leaving, congratulations on your white coat. Yeah, so you guys are getting this question right. When you're talking about embryo and you're talking about the pathology, make sure you can describe what's happened. And so this is one of those things. So it's collection of fluid in the tunica vaginalis. Please make a list of all of these pictures too, because if there's any radiograph, that is fair game. And if they can use it to help distinguish, they'll use it, but make sure you can describe all of these things. So collection, yeah. Hoping this is an easy one. Yeah, everyone's pretty much getting this correct. So if you have a positive anterior drawer test, it's the ACL that is likely damaged, and then the posterior drawer test, of course, is the PCL. The reason being they're supposed to protect you going anterior versus posterior. So if you can displace it anteriorly, that means there's no protection against mechanical displacement. Cutaneous innervation, guys, please, 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 please know your cutaneous innervation. So the answer here is going to be the sural nerve. So I apologize, the right one on here came out really, really blurry, but the lateral side, the most lateral little slip there, that little sliver of skin, that's going to be your sural nerve. And then the deep fib, that's a really big one to be tested, because when you're talking about the dorsal foot, it's that little sliver in the interweb space between digits 1 and 2. That's a really big tested one. So please make sure you know all of your cutaneous innervation. It will show up pretty heavily on the exam. So draw it out however it makes sense to you. Draw on yourself if you like whiteboarding like I do. But that is my last question for you guys. But I'm gonna go ahead and post this on my drive. We will post the recording for you guys when it is ready. Again, that takes a little bit of time to process and then get it edited down a little bit, but we will post that on both of our drives like we always do, as well as all of the resources that we used today. Brady already said this, but we have an exam next Monday, so we will not be doing reviews this next weekend. So we wish you luck on everything.
Yeah, for sure. Like Lindsey said, we'll get this posted. I'll try to get it up later today. And once again, congrats on your white coat. Huge step. And we'll get back with y'all as soon as we get our test over with, and we'll figure out where everybody's at. So with that being said, I will stop the recording.